Good evening, all the aspirants. The class for today is Endocrine CCS session, class 2. And the speaker that we have here is Dr. Shraddha Patharkar. She is Associate Consultant at ABMH Hospital, Pune. Yes, ma'am, you can carry on.
So, we'll start with a case 40-year-old female liver transplant recipient on Visolon 20 mg and Pangraph. Cause for her live donor liver transplant was autoimmune CLD. Presented to ER in a drowsy state with decreased appetite, poor intake, generalized weakness, persistent lethargy, history of weight loss over past 6 months, and now complaining of occasional abdominal pain, nausea, vomiting. She had dizziness upon standing up, as she told. The family relatives told, and the patient gives a recent history of travel, upper respiratory tract infection also, for which she was treated on OPD basis. So, on examination in ER, her heart rate was 100 per minute, BP of 85 by 45, saturation 92% on room air. She was tachypneic 25 per minute. Mild basal crepes were present. Neurologically, she was E2 M5 V2. Her abdomen was soft, non-tender. On physical examination, we noted that there is hyperpigmentation on her palmar creases, knuckles, and oral mucosa. So, from this, just the history part and vitals, can anybody tell me what are the differentials? Patient with liver transplant recipient in a drowsy state with abdominal pain, nausea, vomiting, low BP. What is the commonest like possibilities in differentials that is coming into your mind? Forget about this as an endocrine class. It's just general case. So what you can think of from the
Patient can
history?
have ma'am.
Sorry.
Patient can have hypoglycemia, metabolic acidosis.
Yeah, but what from the case history, what she might have, why she had low blood pressures and
Addisonian crisis. Addison.
It's a post-op case, ma'am. Patient can have septic shock.
very good.
Uh, patient can have some myocardial infarction, acute myocardial event.
She has abdominal
Pancreatitis.
pain, nausea, vomiting.
Patient can
Pancreatitis.
uh,
So
if
acute gastroenteritis, hypovolemic shock, septic shock. From the history, it can be abdominal sepsis, it can be pancreatitis, acute gastroenteritis. So don't go to this adrenal insufficiency directly because you know this is endocrine. Clinically, the from history point of view, this looks like a septic shock in immunocompromised patient. So this the causes for the septic shock might be like from bacterial, fungal to parasitic, and you need to see whether it is a distributive shock, hypovolemic shock. So now you can tell that this is it looks like a septic shock in immunocompromised patients. We source might be abdomen because she had abdominal pain, nausea, vomiting, and but the physical examination is typical of hyperpigmentation on palmar creases. So it looks like adrenal insufficiency, also adrenal crisis. So when the ABG was done, the pH was 7.24, bicarb of 18, PaCO2 of 30, chloride of 114, sodium of 128, and potassium of 5.8. Can anybody interpret this ABG? Uh, can you see it now? Okay. Please read ABG. pH of 7.24, bicarb of 18,
So it
PaCO2
is
of 30.
metabolic acidosis.
Yeah. What kind of
No,
metabolic acidosis?
normal anion gap.
Very good.
With
What is the anion gap here?
anion gap now. Sodium is 121, chloride so 7.
Okay, fine. So it's
It is minus.
the quicker way to find it out is also look at the chloride. If there is a hyperchloremic metabolic acidosis, and bicarb is not that high, it is at 18. So whenever chloride goes up, bicarb should go down, and if the bicarb is not that low, probably you can guess it as just pure nagma. And even the here anything. What is the other abnormality? Electrolytes.
Hyponatremia and hypokalemia.
Yes. So can you give me
But
differentials of hyperkalemic metabolic acidosis?
Addisonian crisis is one, and
Yes, mineralocorticoid deficiency. You can call it as a mineralocorticoid deficiency, type 4 RTA, renal tubular acidosis, because of mineralocorticoid deficiency. Other possibilities being early.
Oh,
Yes,
yeah.
you can. Yes, because even they are aldosterone antagonists, so they also present like spironolactone, AC inhibitors, ARBs, LMWH, drugs related.
Thyrotoxicosis also can.
Sorry,
Thyrotoxicosis can cause hyperkalemia, I think, with hyponatremia.
I'm not getting it. All
Thyro-
potash
th- Thyrotoxicosis?
thyrotoxicosis. Uh, yeah, it might cause if it causes rhabdomyolysis. So even early uremic renal failure, obstructive uropathy, your long-standing CKD because of SLE, autoimmune glomerulonephritis, all of those, even the transplant rejection, all of these can present like this. So here what will be the next step? So anyways, I've written here. But whenever patient is presenting like acute abdomen in shock, so first we need to rule out the other differentials also, whether patient is having any pancreatitis or liver transplant, graft related some issues is there or not. So first and foremost, imaging what you will do bedside is ultrasound. So USG was done and it was suggestive of no hepatosplenomegaly, no ascites. Pancreas was obscured by bowel gas and the left kidney outlining was not appreciated. So see, this immunocompromised patients, you should not wait longer for imaging. So immediately when ultrasound was not showing anything, CT scan was planned. And meanwhile, you will send all the labs. What labs you will send? All the routine labs. Apart from that, what specific labs you want to know?
Cortisol level.
Yes, but unfortunately, patient is on Visolone, so that won't be a very accurate reflection of the underlying state. But still, yes, cortisol level is important. And see, here the adrenal insufficiency or adrenal crisis is because of whether it is an acute underlying condition or the chronic one. Patient is of autoimmune CLD. So patient might have autoimmune adrenalitis also. There is a possibility. So again, Addison's patient might be having Addison's disease, which was now precipitated, went into crisis because of underlying infection. So other so when there is autoimmune adrenalitis, is it a primary adrenal insufficiency or secondary?
ACTH stimulation test.
Yeah, but if okay, fine, you do ACTH stimulation test, and this is the result. Can you interpret it? So random serum cortisol of 7, what it indicates?
Not showing again.
Okay, can you see it now?
Yes. Yes.
So random serum cortisol level of 7 microgram per dl, what it indicates?
Can you
Normally,
show normal level, normal range?
no.
No,
I have not
show normal range,
like,
please.
see, patient is under a lot of stress. Patient is in shock. Patient is under a lot of stress. Normally, serum cortisol should be quite high. Whenever the levels are less than 7, 7 or less than 7, you can surely diagnose that as it's adrenal insufficiency. If it's beyond 20 microgram per dl, then it rules out your cortisol deficiency. But if it's in between, you have to rely on ACTH stimulation test. So your random cortisol level of 7, it indicates already low levels. With such a high stressful response of infection and shock, the levels are still low. When ACTH stimulation test was done, generally they do it with 250 mics of post-intropine, and after 60 minutes levels were rechecked and the cortisol level is 9. Initial was 7 and now the level is 9. So what it
Secondary.
indicates?
Secondary.
This looks like primary is aldosterone
No.
level is also low.
I think this primary because not increase from 7 to 9, not increase more. And another thing, hyperpigmentation will go with primary. Patient has hyperpigmentation in the palm.
Yes, very good. See, the ACTH stimulation test, what it indicates is there was no increase in a cortisol level to the ACTH challenge. Normally, ACTH should stimulate adrenals to produce cortisol. But here there is a problem in the adrenals. That's why we have given ACTH externally. And still there is no increase in the cortisol. It means primary pathology is in the adrenals. And here the ACTH level is normal. 5 to 52 is normal range, and here patient is having 15. So when the ACTH is normal means secondary pathology is ruled out. Either in primary adrenal insufficiency, when the adrenals is the problem and the pituitary hypothalamus, they are not a problem. Either the ACTH should be high, ideally it should be very high, or it can be normal also, depending upon whether this autoimmune disease has affected pituitaries also. But definitely low ACTH indicates secondary reason. Low ACTH means pituitary is not producing enough ACTH, and that's why adrenals are not stimulated to produce cortisol. This is very important because this will come as a in CBS also. There are you need to get this concepts clear. So in primary adrenal insufficiency, ACTH is mostly high, but if associated autoimmune pituitary problem is also there, it might be normal. But pure secondary adrenal insufficiency, ACTH should be low. So again here aldosterone level is also low. What it indicates?
This indicate primary.
No, I mean it indicates the whole gland is involved. It's not just the glucocorticoids, but the aldosterone levels are also low. So it's a primary disease. Mostly in primary
Yes,
adrenal insufficiency, when there is a
Glucocorticoid and
secondary
mineral
problem.
corticoid.
Sorry?
Glucocorticoid and mineral corticoid. Aldosterone is the low.
Yes.
Isn't it
Both are low.
cortisone?
Yes, both are low means entire gland is involved. When ACTH, if the problem is only with the ACTH, generally glucocorticoids should get affected. It's when it is this helps in differentiating primary versus secondary. When there is a mineralocorticoid deficiency also along with glucocorticoid deficiency, it's a primary. Whenever there is a hyperpigmentation and ACTH high, it is primary. And even the electrolyte abnormalities, that if it is In our case, there is a hyponatremia, hyperkalemia. It also indicates it's the primary cause for the adrenal insufficiency. And it might be chronic adrenal insufficiency. So chronic adrenal insufficiency, because of commonest cause in developing country is tuberculosis. In developed countries, it is autoimmune. And this patient had autoimmune CLD that led to transplant. Probably other autoimmune associations is also common. So Addison's disease is the possibility in this case. Young patient. But again, he has a history of weight loss. So even tuberculosis, we need to keep that in mind. If elderly patient with history of weight loss, similar situation, you have to consider malignancy, paraneoplastic syndromes. So your case might come as it may come in any way. So you need to know the differentials. What can lead to primary adrenal insufficiency? So many a times it is the chronic condition precipitated by triggers. In our condition, trigger was infection. Started with URTI, upper respiratory tract infection. And crisis patients present with abdominal pain and nausea vomiting. So they mimic like gastroenteritis, or gastroenteritis itself can precipitate adrenal insufficiency. Either of the things is possible. So you need to know the differentials, etiology, risk factors. Another being secondary pituitary problems might be because of again malignancy, pituitary tumors, neurosurgery. Acute adrenal crisis is little rare, and which occurs because of, if it is a primary, it is because of the hemorrhages in adrenals. Waterhouse-Friderichsen syndrome. And it is also a type of, it's most commonly in meningococcal septicemia. Because of the sepsis, microvascular thrombosis occurs in the adrenals, and later that converts into hemorrhage. So that is the reason for acute adrenal loss or insufficiency. Another cause for acute adrenal insufficiency secondary is pituitary apoplex. That is acute in pituitary infarct or hemorrhages post PPH, traumatic PPH or atonic PPH. If patient is presenting like adrenal insufficiency, that might be the acute cause. And in all the chronic causes, there will be some precipitating factor that pushed patient into crisis. This is very important to understand. What are the chronic causes? What are the acute causes? What are the primary causes? What are the secondary causes? So in labs also, when we did labs, CBC was showing HB of 9, platelets of 1.3 lakhs, WBC 13,000, eosinophils 10%, lymphocytes 43%, and the ratio of neutrophil to lymphocyte is 4. Does it carry some significance? Even that, this also tells you about cortisol deficiency. Because normally cortisol, if levels are adequate, eosinophils should be lower. Lymphocyte count should be lower. But whenever there is an inadequacy of cortisol, these counts go up. So in sepsis, generally neutrophil, if it's a bacterial, neutrophil count should go up. But here the eosinophil and lymphocyte count is going up, and the neutrophil to lymphocyte ratio is going down. Again, that points towards cortisol deficiency. These patients may have multi-organ dysfunction also. So septic shock, multi-organ dysfunction, patient, the case might look like a septic shock with multi-organ dysfunction, but it might be actually adrenal insufficiency. And what is the difference between septic shock and adrenal insufficiency? Both are distributive shocks, but the fluids and the vasopressors will work quickly in septic shock. I mean, at least patient will respond to that. That is the primary management. While in adrenal insufficiency, though you start with fluids and pressors, patient will not respond to this. And once you give steroid, within 1 to 2 hours, patient's blood pressure goes up. So that is a main differentiating feature. So again, the management, how you will manage this case. So always remember, in immunocompromised patients, you need to give broader spectrum antibiotics. In all cases, you have to utter airway breathing circulation. Our patient is drowsy. Patient has a GCS of 9 out of 15. So borderline, if patient's GCS drops, becomes more drowsy, better to secure the airway. Breathing circulation. Circulation is important. Give fluids, start noradrenaline, and you are suspecting adrenal crisis, so immediately give 100 mg hydrocot followed by 50 mg QID. So this is the main treatment. Of course, you need to correct the electrolyte imbalances also. So in last lecture also I told you, in initial part, whenever you are giving hydrocot more than 50 mg in a day, no need to supplement that with fludrocot, because hydrocot has a very good mineralocorticoid cover also. Unlike Dexa, if you are using Dexa doesn't have a mineralocorticoid cover. Again, treat the underlying cause. If the precipitating factor is trauma, it can be trauma, it can be surgery, it can be infections, it can be volume overload, volume depletion, pregnancy. All these are the precipitating factors, or drugs. The drugs causing it, like many a times now, because of this leukemias, lymphomas are getting treated with immune checkpoint inhibitors or CAR T cell therapy for lymphomas. All these also can cause inflammation in adrenals and pituitary, and that can lead to adrenal insufficiency. So all the drugs also you need to be aware of. So in next vignette, the patient got stabilized and shifted to ward on tablet hydrocot. Once patient gets stabilized, you have to continue 50 mg QID for 3 days, and then you shift to the maintenance dose of steroid. So here the tablet hydrocot 20 mg at 8 am and 10 mg at 10 pm was started with fludrocot, because now here the dose is reduced. We need to supplement with fludrocot. His immunosuppressants were continued. So next day he was irritable, confused, not obeying, had uprolling of eyes, labored breathing. Sugar was checked, it was 130. ABG did not show any CO2 retention or any cause for his confused state. Sodium 138. Heart rate is 100 and BP is 160 by 105. He got intubated for the airway protection. So what you will do next, and what do you think, what has happened? Why he is so irritable? He got better, he got shifted to wards, and now his CNS status deteriorated. He's having encephalopathy. So what are the DDs, differentials, and what you will do next? Anybody?
CNS infection or increase ICP or
Okay, raised ICP, but why? Because of the food. See, you have to utter all the encephalopathy reasons till the time you come
rapid,
to.
uh, there is rapid correction of sodium
Okay, good.
demyelinosis.
So pontine
Demyelinosis.
osmotic demyelination syndrome. That is one of the possibilities. Very good. What can be the other possibility? All the
CNS infection.
You can utter metabolic encephalopathy. Yes, it can be the possibility. Patient is on steroid, immunosuppressants, some brain abscess, anything might happen because of low immunity.
Some vascular problem or the syndrome.
See, I have not mentioned about CBC and all, but first and foremost, this metabolic parameters, metabolic encephalopathy. Then you have to think about any structural problem, any IC bleed. Here, but the pupils are equal reacting to light. So you have to rule out any IC bleed, any new stroke, all the structural as well as the metabolic causes, toxic encephalopathies, thiamine deficiency, Wernicke encephalopathy, any autoimmune, because patient is having any underlying autoimmune diseases, autoimmune encephalitis. All the encephalopathy reasons you need to know. And very important, seizures. It might be because of hyperammonemia, या फिर osmotic demyelination syndrome, or some other electrolyte imbalances, magnesium deficiency, calcium deficiency. So seizures, because he is just having uprolling of eyes followed by low GCS, and if patient is not arousable, then non-convulsive status epilepticus, all these things also you have to attend. Even toxic encephalopathies, some medication related encephalopathy. Here one of the clues is patient was restarted on immunosuppressants, and his BP is, though it's not very high, but he had a very low BP. From that low BP, suddenly that this BP is attained. He was having, because of insufficiency, persistently low BP, and now already he has gone through septic shock and other things, and now the BP is this. So what you'll do next? As I told you, in immunosuppressants, imaging should be done as early as possible. As compared to healthy patients, it's better to get imaging done quickly. So whenever CNS status deteriorates, what you do generally? When patient gets intubated and CNS, if you want to check,
CT, MRI, angiography, EEG.
yeah, the first foremost is you need to rule out the bleed, because that will be like your prognostication will depend on that, how aggressively you need to go and what has happened. So first quickly you'll do CT brain. So CT brain is the first thing that you'll do in such cases. When you are not finding any metabolic reasons and suddenly patient has suddenly become drowsy. So is any structural cause, bleed, infarct, abscess, anything like that. So CT brain was done and it was showing hypodensity. So the MRI was planned in the same setting. So MRI was done, and this is the picture. So what it indicates?
Graves syndrome.
Yes, very good. So you can see this hyperintensities in T2 and the flare images. AB, they are the flare images, and DE, they are the uh, T2 images. And specifically the location, you can see this. What it indicates, this hyperintensities indicates what? Presses because of the,
Brain edema.
yes, that is a vasogenic edema. You have to utter this word. Cytotoxic edema is different and vasogenic. So here it is because of a high blood pressure. Many times press can happen even with the moderate blood pressures. Not necessarily it should be always high, because of the endothelial dysfunction, as in preeclampsia. Even with 150 by 90 patient, that pregnant lady can have press syndrome. It's because of the endothelial dysfunction. So this is the press, and what was the reason for the press in this patient? Liver transplant on immunosuppressants. What can lead to press? Here the tacrolimus, cyclosporine, so cyclosporine inhibitors, all those immunosuppressants, it's a very known complication for of press. So you need to know all the causes of press. Anything that leads to hypertension. So whether it is renal failure causing hypertension, or sympathomimetics, any drug abuse, uh, cocaine and LSD, and sympathomimetic response, even that can cause press. And you need to know the differentials of this, uh, similar to press. So whether it is cerebrovenous sinus thrombosis, your osmotic demyelination, leukoencephalopathy, autoimmune encephalitis, these are all differentials. But this MRI is classically, it is indicative of press, though name is posterior reversible encephalopathy syndrome. Most of the times it is reversible, it has a good prognosis, but some patients may have irreversible brain damage even with press. So name is a little bit misnomer, and not always it is posteriorly present. It might present into some other areas also. But again, the problem here, irreversibility occurs when if it is posteriorly involving larger area of white matter, and that causes hydrocephalus because posterior space is small. So even the patient might develop hydrocephalus and you might need EVD. So all these things also you need to keep in mind. So despite, okay, so again, here patient had uprolling of eyes and deteriorated sensorium, and patient has press. So how you'll manage this case? What you'll do? What is the management of press?
Blood pressure control mainly.
Yes. So which agents you'll choose? Prefer?
Like labetalol and sodium nitroprusside.
Okay, but the calcium channel blockers, beta blockers are preferred, and not NTG or anything. This venodilators that increases already pressed. There is a blood-brain barrier that is breached. Autoregulation is lost because of the high blood pressure or endothelial dysfunction. So anything that increases the intracerebral volume, you should not use NTG or nitroprusside. It's better you should go for beta blockers, calcium channel blockers. If uh, enalapril, all these things, if there is no any other contraindication. And what else is the very important treatment as a part of this? There was a uprolling of eyes. So what you'll do, give along with it, along with antihypertensives.
Anti-epileptic drugs.
Yes, you need to supplement them with Levipil. If patient is having convulsions, then midas. But unfortunately, if convulsive, then you can follow our algorithm of uh, giving benzodiazepines in first initial part, and later on the second generation agents like Levipil, phenytoin, and all. But for if it is non-convulsive, we don't have a level 1 recommendations, but we can choose Levipil, and you can give midas also. So, despite being off sedation and paralysis for 12 hours, patient's GCS was even M3VT. Bilateral pupils equal and reacting to light. What you'll do next? So, he was intubated. He was started on antihypertensives, antiepileptics, Levipil, but and he was not given any sedation or paralysis for neuro assessment. But his GCS is even M3VT. So what you'll do next? What you are suspecting now? He's not waking up, and we have
EEG
done MRI.
monitoring for
Yes,
non-convulsive fits.
very good. So now next thing, patient had uprolling of eyes means we know he had some seizure, and generally post-ictal state lasts for 1 or 2 hours. But if even despite that off sedation, if patient is not waking up, you have to suspect non-convulsive status epilepticus, which is very underdiagnosed in ICUs, and it has a poor prognosis because it gets detected very late, or sometimes it is undiagnosed, undetected. So this is the EEG. EEG was done, 60 minutes EEG was done, and this is the pattern. So you need to go through some basic EEGs. Here there are like periodic discharges, lateralized periodic discharges. It's only in the odd leads, so it is lateralized, and the spike wave patterns is there periodically. So mostly lateralized periodic discharges, they are seen in metabolic causes. So here it might be a rapid correction of sodium that may have led to this. generalized discharges is because of metabolic causes. Lateralized discharges might be because of some local pathology or etiology. So here it might be because of this vasogenic edema, because of press. So there are like some important like generalized periodic discharges, lateralized periodic discharges, bifrontal indeterminate posterior discharges. There are certain EEG patterns you need to know. So again, here if the can anybody tell me the definition for non-convulsive status epilepticus when you label it as status epilepticus? So status
Maybe
epilepticus.
meningitis, encephalitis,
No, I mean
maybe
duration.
uh,
When you label it as a
very.
status epilepticus.
Now status epilepticus more than 5 minutes without regain to conscious living.
Yes. Normally, the convulsive status epilepticus is when the seizures last for more than 5 minutes, or their patient seizes and it doesn't come to the baseline. It's in a post-ictal state, and again he has a seizure episode. So in between seizures, he is not coming to the baseline. Then also you label it as a status epilepticus. But that is for the convulsive. This is non-convulsive. For non-convulsive status epilepticus, if because clinically there won't be any seizure. Electrically, the seizure activity lasts for more than 10 minutes, and the seizure activity should be more than 2.5 hertz. So this is the criteria. Or for a 60 minutes EEG, 1 hour EEG, 20% of the EEG strip is showing spike and wave pattern or the seizure activity. Then also you have to label it as a non-convulsive status epilepticus. The criteria for convulsive it is more than 5 minutes, and for non-convulsive it is more than 10 minutes with a more than 2.5 hertz. There are different criteria also, but will not go into that. Why it is important to diagnose seizure versus status epilepticus? Because the prognosis is very poor with status epilepticus if you don't treat it. You have to treat status epilepticus with which medications? You have to use IV anesthetic agents, and patient might develop hypotension. So you have to be cautious. You have to have a central line, arterial line, and you need to start IV anesthetic agents like midas. You have to continue this levi pill, but once it's the status epilepticus, you have to go for IV anesthetic agents like midas or propofol till the target is burst suppression. And once you attain your target of burst suppression, you need to continue these medications for 24 hours at least, and then taper off. So again, management we have seen, and you have to main reason for the what is the etiology, you need to reverse it. So this is the last minute where the husband asks. Now the patients we have managed this patient. He's seizure free. We have started weaning on pressure. A patient is on a pressure support mode, and now husband has so many queries about her. So he asks that what led her to her current condition, and how much time will it take for a complete recovery, and will she have a lifelong risk for the similar episodes of seizures, and if so, how to manage it. Will all this can affect her transplanted liver also? So anybody can take this. So he's asking why this praise has happened, and how long will it take for her complete recovery, how long these medications we need to continue, or whether we need to continue these anti-epileptics lifelong, and what will this affect her transplanted liver. So anybody can utter just whatever you think This is the last we need. So you need to know.
In like this question, they need the real facts or they need the approach only. How I'll explain.
No, so many a times, like in this case, you need to know what can happen with press. So it's a press is a posterior reversible encephalopathy syndrome.
So
So
it's
it's a
completely reversible.
it's most of the times it has a good prognosis, most of the times. But unfortunately, sometimes in 1 to 4% of the cases, they may convert, they may have epilepsy, lifelong threat. So you need to utter this, that the prognosis for press in 80%, 90% of the cases is good, and he might need his her antiepileptic. She might need her antiepileptic medications for 1 or 2 weeks. Then we'll taper it off. But if at all she throws seizure again once she gets discharged, we might need to continue it for a little longer duration, and we need to keep follow up. And if at all, if there is a 1 to 4% chance that it might be irreversible, and she might need to be on those medications lifelong. So will that affect her transplanted liver? So there are certain antiepileptics which are like enzyme inducers. Uh, so we need to check the levels in the blood. But anyways, for such patients, we give hepatosafe anticonvulsants. So we will choose such medications that will not affect her liver. And the reason for press is for her is immunosuppressants. So the tacrolimus, which is one of the agents in the group from cyclosporine inhibitor, that was the that is a common side effect, drug side effect. So we might need to use another medication instead of that. So basically, though it was an endocrine case, in last case only I have covered almost in CBS, because endocrine is not a very vast topic. You have only 3-4 cases, but in as a complete case, adrenal insufficiency is very common. And unfortunately, now you know this is the endocrine topic. That's why you can diagnose it as adrenal crisis. But many a times, this adrenal crisis looks like septic shock with multi-organ dysfunction. Again, this deficiency of cortisol that causes leaky capillaries, and therefore patient might have ARDS lungs. This also reduces the vasoreactivity. That's why the vasopressors won't work unless you give patient the steroids. So these are very important points that and you need to know certain important trials, corticers trial, adrenal trial. Even in septic shock, the stress dose of steroid, they will ask, is there any mortality benefit? So there is no mortality benefit, and though it only improves the hemodynamics. But for adrenal crisis, that is the mainstay of the treatment. Patient, if it is because of adrenal insufficiency, patient improves, hemodynamics improves in 1 to 2 hours. But again, if the precipitating factor is sepsis, septic shock, then it may take little longer, because here both the distributive shock is both because of septic shock and because of adrenal insufficiency. So actually I covered the different topics also in this, because in exam also your viva will not just go into that one case, it will lead you through different topics. So you need to know about, like, encephalopathy is very common. In any case, patient may have encephalopathy, whether it is metabolic related or septic encephalopathy is a diagnosis of exclusion. So first you need to rule out many other things, and you need to utter all the electrolytes. You need to send all the electrolytes whenever there is encephalopathy. An immunocompromised patient, again, broader spectrum antibiotics, sending cultures, I did not go through all of that, but in definitely your approach is important. Even if you don't come to the conclusion immediately of adrenal crisis, it's okay. But how you manage septic shock, 1 hour bundle, sending cultures, giving broader spectrum antibiotics, uh, looking at the lactates trend, all this in initial part is very important. Patient had a URTI history, so and patient saturation was also less. So that was because of either leaky capillaries because of steroid deficiency, cortisol deficiency, or it can be because of the sources lung. So you need imaging, and chest X-ray in immunocompromised will not pick it up. So if patient is not on a very high pressors in shiftable to CT for CT, it's better to get HRCT done. It's better to get CT abdo done. Or whenever this CNS suddenly deteriorates, the first and foremost is you have to rule out bleed. Patient was in septic shock. Patient may land up into DIC. So all of these things you need to consider, and you have to utter very important things like CT brain. You have to utter in whenever patient's CNS state deteriorates, because the next vignette will be they'll show the CT report with some bleed or midline shift or maybe hydrocephalus, and then or maybe ICP monitoring. In last exams, they asked about the ICP monitoring also. So we'll end the uh, today's session here.
Thank you.
Yeah,
Thank you, ma'am.
Thank you, ma'am.
yeah.